Hi, my name is Diana Rule, and this is my EBP on the effect of nurse-to-patient ratios on patient care. The purpose of this presentation is to discuss the importance of safe nurse-to-patient ratios and the effect it can have on patient care. Currently, California is the only state to require minimum nurse-to-patient ratios that must be maintained at all times. For every patient added to a nurse's assignment, their risk of mortality increases 5% within 30 days of admission. That is so significant and important. And the reason that this topic is important is because of the high incidence of understaffed hospitals and the continued poor patient outcomes. The PICO question is, in the acute care setting, what is the effect of safe nurse-to-patient ratios on patient outcomes compared to unsafe nurse-to-patient ratios? P is patient, I is safe nurse-to-patient ratios, C is for compared to unsafe, and O is patient outcomes. The literature search was obtained through multiple databases, including the Google Scholar, EBSCO, and Open Athens. Subject headings include nurse shortage, staffing, and patient outcomes. This was then narrowed down by peer-reviewed articles, academic journals, and the year of publication. This narrowed down the search to 4,400. Articles were then chosen by primary resource studies and pertinent data to the EBP study. The literature search was challenging at times because of the amount of information that can be found, which made it difficult to sort through each study to determine appropriate articles. The literature synthesis was interesting. So the articles are all different when compared to one another because they all look at different patient outcomes, but the study that was conducted by Hodgkins and Morgan and Peterson was totally different from the study done by West-Barron and Harrison and Rafferty because it's looking at patients that were admitted for pneumonia. But when they were properly staffed, they were able to look at secondary problems that the patient had. They were able to catch these problems, while the other study looked at reducing patient risk of mortality rates in the ICU. So then there's similarities in that the West-Barron, Harrison, and Rafferty study is similar to the Chow, Sloan, Kim, Choi study because they both examine patient mortality and how patients are more at risk for mortality when nurse-to-patient ratios are high. The study completed by Morita, Matsui, Fushimi, and Yasunga is similar to the Sheets, Dimmick, and Graver study because they both examine the prevention of adverse patient events in comparison to nurse staffing. The study completed by Morita, Matsu, or Fushimi, and Yasunga showed how nurses can prevent inpatient fractures by being properly staffed, while the study by Sheets, Dimmick, and Graver examined nurse-to-patient ratios in relationship to failure to rescue following a major surgery. So these studies are looking at different outcomes in comparison to nurse-to-patient ratios, but sometimes they're looking at similar things like mortality rates, or they're looking at adverse events that nurses could catch. Something interesting with the Hodgkin, Morgan, and Peterson was that these nurses were working in California and they had enacted their nurse-to-patient ratios, and because they were adequately staffed, they were able to catch these secondary conditions like anxiety and depression, and because they had enough staff to treat them. So that can really affect patient care in the future. By reducing readmission rates, hopefully getting them treated and getting the care that they need. Another study by West-Barron, Harrison, and Rafferty was different from the rest of the studies because it looked at ICU patients, but it also examined not just nurse-to-patient ratios, but how much support staff they had and physicians. But the big thing that was significant with this study was that when nurses were appropriately staffed, the risk of death went down. And even when you adjusted the physicians being staff or the support staff, it didn't affect the mortality rate, but the nurses being staff did affect the mortality rate. Another study about nurse staffing showed from the study was conducted by Choi, Sloan, Kim, and Chui, showed that for every patient that was added to a nurse's assignment, there was a 5% increase in risk of mortality within that 30 days of admission. So while this study is still looking at mortality, it's looking at the increased risk, like what is the percentage. So that is different from the other studies. The nurse staffing also impacts the patient care by preventing adverse events, and kind of talked about this a little bit already, but the Morita, Matsui, Fushimi, and Rusunga study is related to the Sheet, Stimmick, and Graver study because they're both looking at adverse events, but they're just looking at different outcomes, like postoperative complications versus inpatient fractures. So all 5 articles, when you look at them, really come to the same conclusion. They really show that nurse-to-patient ratios matter, and they're significant, and they're important. The most significant study, I think, was the ICU mortality study because it looked at specifically the nursing variable and how even though you can change the amount of people that are supporting them or even physicians, it is the nurses that were really the factor in mortality. Challenges when completing this literature synthesis, I think, were finding the primary sources that are within that time frame, but also relate to one another and build upon one another. All topics conclude that there is a direct effect and that nurses do have an impact on patient outcomes. So when I look at practice recommendations and management from here, the evidence is clear that change needs to happen. Nurse-to-patient ratios need to be regulated in order to protect nurses and the patients they care for. So these recommendations are similar to the UNAC-Kaiser recommendations for California. So critical care, NICU, L&D, PACU, all should have minimum 1-to-2 ratios. Postpartum, 3 couplets, and critical care step-down unit 1-to-3, while the ED kind of has a range of 1-to-1 to 1-to-3, depending on the acuity. The OR is 1-to-1, and telemetry med-surg is 1-to-4. So when I look at the studies conducted by West, Barron, Harrison, and Rafferty support the EBP that nurse-to-patient ratios affect patient outcomes, including prevention of mortality, as well as the study conducted by Chow, Sloan, Kim, and Choi. Those absolutely support the EBP. A couple other articles that were found and are significant are this study that was conducted by McHugh, Rockman, Sloan, and Mancini, concluded that with better nurse staffing and work environments, there's an increase in patient survival rate and an inpatient or in-hospital cardiac arrest. Yet another study conducted by Twigg, Gielhoyd, Bremer, and Duffield found that when increased nurse staffing was implemented, fewer failure to rescue events occurred, as well as pressure ulcers, falls, and cardiac arrest. So what are the challenges that these recommendations face? Well, staffing's expensive, and I think there are many hospitals that maybe wouldn't want to pay for the increase in spending on staffing, but it's clear that it's worth it. I think there's also a culture shock. It's always been done this way. I think most people have heard that in the profession. EBP shows, though, that that's not a good reason to continue doing what you've been doing. If it's not working, then things need to change. So I do think it would be challenging, though, to get establishments and management to change and implement these nurse to patient ratios. So to kind of bring it all together, and here's just some key takeaways that I hope you take away from this presentation, is that it's clear that nurse to patient ratios have an impact on patient outcomes. There's significant data and research to support EBP. The cost of hiring and scheduling appropriate nurse to patient ratios, it's worth it. And nurses can prevent poor patient outcomes such as fractures, ulcers, falls, cardiac arrest, postoperative complications, and even mortality. I hope that you've enjoyed my presentation and have taken something from it. These are the references that I used. And if you have any questions, I'd be more than happy to answer them. Thank you so much.